This is just a picture of non-invasive machines. We do have dedicated non-invasive machines, plus we have regular ICU ventilators which can also be used, and they qualify to be used as for non-invasive ventilation. So what do you mean by non-invasive ventilation? Non-invasive ventilation is the delivery of ventilation to the lungs without an endotracheal tube or means of a tracheostomy. And this is basically to avoid intubation, avoid tracheostomy, so that it is much more easy, much more comfortable. The patients are much more adaptive, can eat, and it is also help you to improve the synchrony between the patient as well as patient and the machine. So that's also equally important, and reduce the complications of invasive mechanical ventilation. So what does this machine do? Basically, it supports each and every breath in simple terms. For those students who are there, it supports each and every breath so that it helps in the reduction of the inspiratory muscle fatigue, and thus the respiratory muscle fatigue goes down. It also delivers the tidal volume to the patient so that the air hunger goes down. And there is a continuous positive airway pressure which balances the inspiratory threshold work related to the intrinsic peak. And NIV improves the respiratory system compliance by reversing the microatelectasis because of the end positive expiratory pressure and the positive pressure of the Cpap. It keeps the alveolus open, and therefore it helps you to improve the oxygenation. And therefore, these are some of the principles how it works. So what are the main advantages? If you see, the advantages, the application, it is very easy because you don't need to have an endotracheal tube. It allows intermittent removal also, so that patient can eat, patient can communicate. It is much more comfortable. It also reduces the need for sedation. And more importantly, here also, if the patient wants to cough, he can easily cough and remove the mask or remove, and then communication becomes much more easy. Important is to avoid the complications of local trauma, aspiration, or the late, such as nosocomial infections, also going down with the help of avoiding of the intubation of this, and therefore it is said to reduce the complications like ventilatory associated pneumonia. So the benefits of giving non-invasive positive pressure in acute care, if you really see, it reduces the need for intubation that's there. It also reduces the incidence of nosocomial pneumonia, and more importantly, it reduces the hospital stay, the ICU length of stay, and thus because of less complications, there is also reduced mortality and improves the patient comfort, and you don't have to give much amount of sedation to these patients. And in chronic care, especially in those patients who are of obesity, hypoventilation, or those patients with obstructive sleep apnea, they are the ones where the symptoms of hypoventilations are better or they are corrected, and therefore it improves the quality of sleep, and the functional capacity also goes down. These patients do not sleep throughout the day, and they also feel quite fresh and energetic to work throughout the day, and it helps them to prolong the survival, and the life is much more better. They can also travel anywhere in the world with the help of these non-invasive support. Now, the potential indicators of success. Yes, India is also one of the largest users, but that means also every plus has got a minus, and we will also have a failure to go up. But the most important to avoiding failure is selecting the right kind of indication for which the non-invasive needs to be started. So you select that the patient needs to be young, the patient should be alert, the patient should be cooperative, the patient should have a better neurological score, or a GCS should not be a comatose patient. There should be only a moderate amount of hypercarbia or a moderate amount of acidosis. Like if the carbon dioxide is above 120, 130, the patient is obtended, then definitely cannot protect the airways. That is not the right way to continue with non-invasive indication. Yes, improvement of the gas exchange and heart rate within the first 2 hours. Yes, you have to select proper indication. Like if there is a cardiac arrest, please do not use non-invasive mechanical ventilation. In a comatose patients, please do not start the patient on non-invasive mechanical ventilation. So the patient needs to protect the airway, which is very important. So the disadvantages, as I told you, yes, it will take an improvement of the gases will occur some time. You will require certain amount of time for the body to adapt and the gas exchange to occur, and that will definitely take some time. Now here, since non-invasively air is going to be delivered to the patient or tidal volume, certain amount of air will also be taken by the patient or he'll be gulping it, and therefore there will be aerophagia, there will be gastric distension. But mind you, the gastric distension occurs in about 2% to 5% of patients. The mask, which is the main interface, if it is not fitted properly, there will be air leaks. And because of the air leaks, if there could also not be a proper delivery of tidal volume, there may be low pressures which is there. There also could be a transient amount of hypoxemia because of accidental removal of it. The air which is leaking can also cause irritation of the eyes. And because of the tightly fitting mask, mind you, the mask needs to be fitted snugly, tightly, but it should not fly with every breath. And that's important. It can also give rise to certain skin erosions or skin necrosis to occur as one of the complications. Now, important thing is there's a lack of airway access. Certain people can also aspirate with this in case if the airways are not protected, if the patients are not obtended, then it's not the right choice because there are chances of aspiration. And more importantly, there is a dryness of the nasal mucosa. These people sometimes also feel dryness of the oral mucosa, and as a result of which, because there is not much amount of humidification which is present here. So what are the types of non-invasive? There being the negative pressure ventilation, which is age-old. This is now the iron tank or the tank cuirasses. Then there be pneumo belts, and the positive pressure ventilation is either the BiPAP or the BI and the Cpap kind of support, where the BiPAP, the two levels of pressures can be given, and a Cpap where there is a continuous positive airway pressure which is maintained throughout the respiratory cycle. So the negative pressures, ventilators, they apply negative pressures intermittently around the patient's chest wall, and the patient's head is exposed to the room air. And this is an example of iron lung or a tank ventilator. I have not used it. This is the photograph, and which is there for your records. I have not used it, nor I have also personally, I have no experience in handling it or seeing it. This is just a photograph for you for me to show it to you. Now, these were used way back, it seems, in certain polio pandemics which occurred way back in 90s, and over a period of time in late 60s when these became available. Now, these were basically applied intermittently to the thoracic areas, and these negative pressures were transmitted to the pleural space and the alveoli, and thus they created a pressure gradient between the inside of the lungs and the mouth, and as a result of which the gas flow occurs. We have no experience in using it. Now, more important is the Cpap. This is commonly used. Cpap is commonly used for, as I told you, it's the word itself tells you everything. It's a continuous positive airway pressure. These are used as mostly in obstructive sleep apnea or in those patients to improve oxygenation in acute congestive heart failure. Because of this, the positive continuous airway pressure, the obstruction of the tongue or the obstruction of the airway because of the tongue which is falls back, that is overcome, and as a result of which the patient can sleep well, the patient's endurance is better with it, and even because of the continuous positive airway pressure, the alveoli do not collapse. It helps you to improve the oxygenation and also helps you to keep the alveoli open and also drive the fluid out of the alveolus. That's what is the advantages of using it. Another form of Cpap, it can be applied through a mask type device, and Cpap usually do not provide a volume change, nor does it support the patient's minute ventilation. However, it is often grouped together in discussions about non-invasive ventilation. Sometimes the machines could also be different. There could be a different modes which are there. Certain machines where those are available for home ventilations into the obstructive sleep apnea, only Cpap kind of machines are available. There may be certain machines which will deliver both the BiPAP as well as the Cpap kind of machine, but the Cpap, as I told you, is mainly used for obstructive sleep apneas and even in hypoxemic respiratory failures, especially for congestive heart failure. Now, the Cpap in hypoxemic failure, what does it do? It mainly recruits the lung. It improves the oxygenation, that is a rapid correction of the oxygenation occurs by improving the ventilation perfusion mismatching. It also increases the functional residual capacity, and because of this, at the same time it supports it. It also helps to decrease the respiratory rate, and therefore the work of breathing is also better. And because of the continuous positive airway pressure, there is also improved hemodynamics because of the positive pressure. There's a decreased venous return. It decreases the afterload, and therefore is very beneficial in patients of cardiac failure. And it also decreases the heart rate so that the cardiac failure also gets better and improved. Now the bi-level is again a pressure support. Mind you, in Cpap, as I told you, it's a continuous positive airway pressure which is maintained. The same pressure is maintained towards inspiration and expiration. While in BiPAP, there are two levels of pressure. Once we have is the inspiratory positive airway pressure at which the delivery of tidal volume occurs at that particular pressure. So that in the respiratory cycle, we can achieve two pressures into one respiratory cycle. One is the IPAP, what we set it, which help you to deliver it, and this supports the machine and helps the patient in its own respiration, and it also helps to reduce the work of breathing by delivery of tidal volume or increasing the alveolar ventilation. And second is the EPAP, which is the end positive expiratory pressure, and that airway pressure, it is essentially equivalent to the PEEP, and it helps to prevent the alveolar collapse, or it definitely keeps the alveoli open and helps to improve the oxygenation, and thus it helps to cause also recruitment. And these some can be used in patients of COPD also, into these patients or those with a mild amount of acute exacerbation of bronchitis.